Hi, and welcome to this 10-minute Tuts on an approach to anorectal abscesses brought to you by the Dr. Coffee podcast. This video falls into a short series on an approach to benign anorectal conditions, the first of which will be this video on anorectal abscesses, followed by 3 videos on anorectal fistulas, anal fissures, and hemorrhoids. Anorectal abscesses are a surprisingly common surgical problem, with the at-risk population being patients who are diabetic, immunocompromised, or people on therapy for autoimmune or malignant conditions, so they're taking chronic corticosteroids, patients with inflammatory bowel disease conditions such as Crohn's disease, and patients who experience sexually transmitted diseases. The signs and symptoms of anorectal abscesses are typically pain in the perianal area with tenderness on a PR exam. This pain can be dull, aching, or throbbing, and pain is the most common symptom of an anorectal abscess. The pain is usually worst when the patient sits down and right before a bowel movement, so usually when there's pressure in the area. They can also be experiencing constipation. They may experience drainage from the rectum of pus or blood. They may have fever and chills. They may complain of a palpable mass near the anus. And most have some overlying skin changes of erythema or swelling or redness in the area. The condition can become extremely painful and usually worsens over the course of just a few days. The pain may be limited and sporadic at first, but may worsen to a constant pain, which can become very severe when body position is changed, such as when the patient is standing up or rolling over and sitting down. Depending upon the exact location of the abscess, there can also be excruciating pain during bowel movements, although this is not always the case. The causes of anorectal abscess are quite various, the most important ones being trauma and infection. So trauma could be due to an infected anal fissure, it could be due to anal intercourse, and cryptoglandular infection in the dentate line is a common cause as well, where the little anal glands that secrete mucus that aid the passage of stool can actually get blocked and infected. Then there could also be infected sebaceous cysts in the perianal area where that infection is actually starting from the skin on the outside of the anus and not from within. And then other medical conditions such as Crohn's disease may have significant perianal disease, including anorectal abscesses and anal fistulas. Anorectal abscesses tend to be classified by their anatomical location. So the various sites of anorectal abscesses include supralevator, ischiorectal, intersphincteric, and perianal, which is the most common. And you can see on this picture from teachmesurgery.com that the various positions of the abscesses are in relation to the muscles around your anal sphincter. If anorectal abscesses are not treated and allowed to worsen, they may complicate, and 1/3 may complicate with a fistula, which is a communicating hollow tract from the rectum to the skin around the anus. The patients may develop sepsis and be unwell, and the infection can spread along the fascia to develop into necrotizing fasciitis of the perineum, also known as Fournier's gangrene. If the muscles of the sphincter are involved and are broken down, there may also be sphincter incontinence, which, as you can imagine, can be a problem for the patients because they're no longer able to remain continent with stool. The diagnosis of an anorectal abscess is usually pretty straightforward based on your patient's history and your clinical exam. However, you do want to do some preoperative investigations such as blood work, a chest x-ray for the anesthetist, and maybe some imaging if there was some unusual circumstances, so you would maybe do an ultrasound of the area to see where this collection exactly is going. In the operation though, remember to send off some of the pus that you drain for MCNS so that you know exactly what kind of bug you're treating. Management of an anorectal abscess is broken down into a surgical and post-operative approach. The surgical approach is to do an incision and drainage in theatre. The patient may be only sedated or with the spinal, but usually is under some kind of anesthetic, typically general anesthetic if the patient is able to tolerate that. And the patient is then put into a lithotomy position. When you're doing the drainage, it's also important to do proctoscopy of the anal canal to make sure that there's no fistulas, because remember that 1/3 of the abscesses can develop a anorectal fistula. You may want to send off a bit of tissue biopsy as well because of the risk of malignant transformation, and don't forget to send off pus culture and to, after doing significant washouts, to give the patient antibiotics if there's cellulitis or fasciitis present. Post-operative management of an anorectal abscess will include sitz baths regularly, that's 2 to 3 times a day, where the patient is going to lower themselves into a bath or into a container of water and gently clean the area, usually with some kind of cleaning solution or even just salt and water to make sure that there's no recurring infection. Then you'll come back to your clinic for wound review in about 2 weeks, and then you want to review the biopsy results to exclude inflammatory bowel disorders and the risk of malignancy. I hope you enjoyed this 10-minute tut and found it useful. If you did, please like this video and subscribe to the Dr. Coffee YouTube channel. The Dr. Coffee podcast is a weekly podcast for South African medical students and junior doctors, featuring interviews with consultants talking about their journey through medicine and the pros and cons of their speciality, as well as other topics designed to motivate, encourage, educate, and inspire. You can find the Dr. Coffee podcast on Apple Podcasts, Spotify, and Google Podcasts, and follow us on Instagram with the username @DrCoffeeZA for episode updates and more. Until next time, best of luck on your studies.